you bring a feminist consciousness to bear on that work. Has there ever been a time when you felt like your feminist values, as they inform your work in women's health and mental health, that there's been any resistance to that, or that there's been any... I'm imagining that most people who work in women's health and mental health are pretty open to feminist values, but has there ever been a time when you felt that that was difficult to negotiate, that it was hard to kind of put those values on the table?
That's a great question. Occasionally, I would say that a lot of my colleagues are quite progressive and liberal and have identities as feminists as well. On the other hand, when there are times when we want to respect a woman's choice that might not be mainstream, that might be that they choose to decline a treatment recommendation, or they don't feel that the choice is theirs, for that matter, since we certainly work with women for whom health choices may not be theirs. If there may be cultural differences in that health choices might be embedded in a family system or in cultural beliefs, that sometimes it's hard when you so want to empower women to take control of their health, to take control of and feel empowered about the decisions they make, that I think the struggles for me have been less with my colleagues and more with having to respect that women have different values and different beliefs. That those have been somewhat more challenging. That most of my colleagues would agree that women are sort of with the value that women should be the central part of the care and the team leader, if you will. But that doesn't always, in the health system, larger health system, work out very well.
I think that's so interesting, and I've even attended some discussions here at AWP about this very issue of respecting the woman's decisions and respecting the context that those decisions may be being made in. Can you maybe elaborate a little bit, because it is such a challenge? Even thinking of some examples where you as a clinician had to kind of engage with that dilemma, and what you kind of did and how you kind of negotiated it.
Well, I think I actually learned a really good lesson back when I was very young, actually as an undergraduate. And we were interviewing, I was a student of Dr. Howard Leventhal's a long time ago. And he had one of the first grants from the NCI on the cognitive, physical, emotional, and behavioral effects of chemotherapy. And we were doing a ton of interviews. And I remember, here I am, young feminist in Madison, I remember interviewing a woman and asking her about changes on her functioning at home because of cancer treatment. And she was talking about that she didn't have the energy to do some of her house chores. And I remember feeling like, when she started talking about her family helping, thinking, oh great, her family members are becoming more responsible and more involved. But when I asked her about it, she didn't think it was so great. That at that point, and never mind that this is this may be 30 years ago, not quite, but almost, that this individual, for a part of her core identity was to take care of her home. And it was a wonderful lesson for me as a young person, that just because I think it's great to have, equity in household chores, that not all women think that's so great. And more recently, that understanding how women view choices around their health. For example, a woman not being so clear that she wants to continue with traditional monitoring for her health after breast cancer treatment, and having some regrets that she might have. I'm blurring examples for confidentiality, but not being so sure that traditional treatment is the way to go, and having to respect that. And then clinically wanting to make sure that while the patient might understand, the woman might understand the impact of her decision based on what we know from science, that I still want to work with her, support her, and understand, is that decision coming out of depression? Is that coming out of the way she views traditional treatments? Is that coming out of lack of information? And so my feminist ideals have to also be I have to be always in check about clinically what am I hearing, and if she chooses to do something non-traditionally, how do I still support that individual? And sometimes that's not so easy. So that's a more recent clinical example that I'm when dealing with